Hello everyone, I'm myself Dr. Rajesh Gubba. I'm the general medicine educator. In this session, I'll be discussing a very important topic in the valvular heart diseases, that is the tricuspid stenosis. So, if you see the basic tricuspid valve, right? What is the basic anatomy of the normal tricuspid valve? The name itself suggests it consists of the three cusps, okay? So, the valve, it consists of three leaflets, right? And what is the names of these leaflets? They are anterior, posterior and the septal leaflets. So these three are the leaflets of the tricuspid valve. And if you take the normal tricuspid valve area, right? If you see the normal tricuspid valve area, it is around 8 to 10 centimeters square. That is a normal tricuspid valve area. And if you see the tricuspid stenosis, among the various valvular heart diseases, tricuspid stenosis, it is a rare entity, right? It is rare. And it is seen in less than 1% of population in developing countries. Right? So that is the incidence of the tricuspid stenosis. And whereas worldwide, if you see, the tricuspid stenosis, it constitutes less than 3% worldwide. Right? So that is about the tricuspid valve and as well as the incidence of the tricuspid stenosis. So in tricuspid stenosis, what exactly happens? There will be narrowing of the tricuspid valve. And for that, you need to know the etiology of the tricuspid stenosis. The history of rheumatic heart disease, it is most likely present. Right? The history of the rheumatic heart disease, it is most likely present. And this particular tricuspid stenosis, let me tell you, this is more common in females rather than males. And other etiologies which will cause tricuspid stenosis apart from rheumatic heart disease is the carcinoid disease. Right, the carcinoid disease. And what is this carcinoid disease? It is the disorder which is characterized by increase in, right, it is a disorder characterized by increase in the 5-hydroxytryptamine. That is what is called as the carcinoid disease. And the other clinical condition which will cause the tricuspid stenosis is prosthetic valve degeneration. Right, prosthetic valve degeneration. So these are the etiologies which will cause the tricuspid stenosis. But among all these, the history of rheumatic heart disease, it is most likely present. Now, this tricuspid stenosis can also be seen after the tricuspid valve replacement also. So, if you take the surgical procedure, that is tricuspid valve replacement, the incidence of tricuspid stenosis after tricuspid valve replacement increases considerably after 8 years post surgery. Okay, so after tricuspid valve replacement, the incidence of tricuspid stenosis increases considerably after 8 years. right after 8 years post surgery. That is what is regarding the tricuspid valve replacement. And in these individuals who have undergone tricuspid valve replacement and who has developed tricuspid stenosis, tricuspid regurgitation frequently accompanies this particular lesion. Okay, so tricuspid regurgitation, this frequently this frequently accompanies this particular lesion. And another important point is that the development of tricuspid stenosis should be suspected when right heart failure appears in the course of the mitral valve disease or in the post-operative period after tricuspid valve repair or replacement. So that is regarding the tricuspid valve replacement. So the incidence of tricuspid stenosis after the tricuspid valve replacement increases considerably after 8 years post-surgery. That is about the tricuspid valve replacement. Then we also have congenital forms of the tricuspid stenosis. See, as you have the congenital forms for the mitral stenosis, there is also what is called congenital mitral stenosis. Congenital mitral stenosis, you have what is called parachute mitral valve. Right, you have what is called parachute mitral valve. Okay, that is congenital mitral stenosis. And similarly, you have the congenital forms of the tricuspid stenosis as well. This congenital forms of tricuspid stenosis, it is rarely observed. Right, it is rarely observed. That is about the congenital forms of the tricuspid stenosis. Now, what will be the clinical findings and as well as the signs in these individuals? Patients with the tricuspid stenosis, they are characterized by having the features similar to that of right heart failure. Right, so these individuals, they'll have features of right heart failure. So why is that they have the features of the right heart failure is that, so this will be the four-chambered heart and this is the tricuspid valve and this will be the mitral valve. So you have right atrium and then the right ventricle. Into the right atrium, there is opening of the superior vena cava, whereas the other important vessel which will open is the inferior vena cava. Right, superior vena cava and as well as inferior vena cava opens into the right atrium. And here what has happened? The tricuspid valve, it is stenosed. Right, tricuspid valve is stenosed. So when tricuspid valve is stenosed, right, when tricuspid valve is stenosed, there will be increase in the right atrial pressure and subsequently there will be increase in the SVC pressure and as well as increase in the IVC pressure. So once there is increase in the SVC and as well as IVC pressure, accordingly what will happen is there will be development of hepatomegaly. Right, there will be development of hepatomegaly. Now why is that there will be hepatomegaly? Once the pressure in the inferior vena cava increases, subsequently there will be also increase in the pressure in the hepatic veins. So once there is subsequently increase in the pressure in the hepatic veins, because hepatic veins have to drain the blood into the IVC, but IVC pressure is very high. So hepatic veins, they are unable to drain the blood in the IVC. So once the hepatic venous pressure increases, subsequently the liver cannot drain the venous blood into the hepatic veins. So thereby what will happen to the size of the liver? It increases. And surrounding the liver, you have what is called the Glissen's capsule. So once the liver size is increased, the Glissen's capsule which is present around the liver, that is also being stretched. And thereby the individual will develop what is called tender hepatomegaly. And subsequently, once there is development of congestive hepatomegaly, right, there is increase in the pressure within the liver, and your portal vein which has to drain the blood into the liver will not be able to drain the blood now because the pressure within the liver is very high. It is a congestive hepatomegaly. So thereby what will happen to your portal venous pressure? The portal venous pressure increases. So as the portal venous pressure increases, the blood from the portal vein, it drains into the peritoneal cavity, and that will make the individual to develop what is called ascites. Okay, so the next important feature is, right, the next important feature is development of ascites. And subsequently, as the pressure within the inferior vena cava increases, there is also development of dependent pedal edema. Right, subsequently there will be development of dependent pedal edema. So this will be the features, the clinical features of the tricuspid stenosis. Then what will be the signs in patients with the tricuspid stenosis? The signs, if you see, the JVP will be elevated, right? And within the JVP, you need to know that there are the waves. And what are the waves in the JVP? The waves in the JVP include A wave, C, X, V, and then Y. So these are the waves in the JVP. And what does the A wave represent? The A wave represent the atrial contraction. So just now we have discussed that in patients with the tricuspid stenosis, the right atrial pressure increases. So right atria has to contract very strongly to push the blood into the right ventricle. So thereby the pressure rise within the right atrium is very high. And thereby the wave, what you will have is the giant A wave in patients with tricuspid stenosis. Right, you have what is called a giant A wave that is seen in the tricuspid stenosis. Okay, and the JVP is also elevated. And you also have the presence of the Kussmaul sign. Now, what do you understand by this word Kussmaul sign is? Kussmaul sign is increase in the jugular venous distension on inspiration. Right, increase in the jugular venous distension on inspiration. This is called as the Kussmaul sign. And Kussmaul sign is not just present only in tricuspid stenosis, it is also present in tricuspid regurgitation, right heart failure, restrictive cardiomyopathy, constrictive pericarditis. So these are all the conditions where you have the Kussmaul sign in patients with you will have the presence of Kussmaul sign. Now, and these individuals, whenever you auscultate, right? So if you take the auscultation, the very important finding is that you will hear a diastolic rumble along the lower left sternal border. Right, you will listen a diastolic rumble, and this diastolic rumble, it is a mid-diastolic murmur. Right, it is a mid-diastolic murmur, and this particular mid-diastolic murmur, it increases on inspiration. Right, this mid-diastolic murmur increases on inspiration. That is what you will see in the tricuspid stenosis. And not only that, when you palpate the liver, right? So I said you that there is hepatomegaly, but when you palpate the liver, it is not just only tender hepatomegaly. You will also feel further diastolic pulsations. Right, diastolic pulsations are felt over the liver. Okay, next. Now, after having discussed about the clinical features and as well as the signs in patients with the tricuspid stenosis, okay, but before that, you take this mid-diastolic murmur. This mid-diastolic murmur, it is also heard in patients with the mitral stenosis. But how will you differentiate mid-diastolic murmur of tricuspid stenosis from the mitral stenosis? See, the murmur of tricuspid stenosis, right, that is mid-diastolic murmur of tricuspid stenosis increases on inspiration. And what is that sign called as? That sign is called as that particular sign is called as the de Carvalho's sign. Okay, whereas you take the mid-diastolic murmur of mitral stenosis, that does not increase on inspiration, but in fact it increases on expiration. That is what is about the mid-diastolic murmur, right? The one which you will listen in both tricuspid stenosis and as well as the mitral stenosis. Then you see about the investigations. See, the first line investigation that you will have in patients with tricuspid stenosis will be echocardiography. Right, first line investigation in patients with tricuspid stenosis will be the echocardiography. Now, what is that you will observe? For example, if the etiology of tricuspid stenosis is rheumatic disease, right, if the etiology of the tricuspid stenosis is rheumatic disease, you will observe the presence of the tricuspid valve thickening, right? So you will have what is called tricuspid valve thickening, right? So that will be the consistency of the tricuspid valve in rheumatic disease. And the other important thing is there will be decreased early diastolic filling slope of the tricuspid valve. Okay, so because you have the tricuspid stenosis, due to which the flow of the blood from right atrium to the right ventricle is decreased. So there will be decreased early diastolic filling. Right, there will be decreased early diastolic filling slope of the tricuspid valve. Whereas, if you see the etiology of tricuspid stenosis as a carcinoid, in carcinoid syndrome, what is the abnormality of the tricuspid valve that you will observe is the leaflets leaflets, they are fixed, but there is no significant thickening. Right, there is no significant thickening. That is what you will have in the carcinoid syndrome. Okay, in rheumatic you will observe that the tricuspid valve are thickened, but whereas in carcinoid the leaflets are fixed but there is no significant thickening. And followed by that you take the continuous and as well as the color flow Doppler. See, when you make out the Doppler studies, what is that you will observe is there will be increase in the pressure half time. So there will be prolonged pressure half time. Now what do you mean by this word prolonged pressure half time? Pressure half time means it is the time required for the pressure in the right atrium to fall to half of it is called pressure half time. I'll repeat again. Whenever the right atria contracts, the blood from right atria will enter into the right ventricle. So thereby what will happen to the pressure in the right atrium once it contracts? It increases. So the time required for the pressure to reduce it to half is called pressure half time. But in case of tricuspid stenosis, or in case of mitral stenosis, the time required for this pressure to reduce it to half within the atria will be more. The time required is more. So there is prolonged pressure half time across the tricuspid valve. Right, there will be prolonged pressure half time across the tricuspid valve. Okay, and this can be used to estimate the mean gradient as well. Right, next. And the other important point is, what is the criteria for severe tricuspid stenosis? Right, what is the criteria for severe tricuspid stenosis? Severe tricuspid stenosis is present when the mean gradient is more than 5 millimeters of mercury. Right, when mean gradient is more than 5 millimeters of mercury, that is the point when we use the word severe tricuspid stenosis. Okay, so that is about the Doppler studies in case of tricuspid stenosis. So please remember, echocardiography, that will be the first line investigation. Rheumatic disease, the tricuspid valves are thickened, right, and there will be decreased early diastolic filling slope of the tricuspid valve, whereas in carcinoids the leaflets are fixed and there is no significant thickening at all. And the next important thing is the Doppler studies. So to call it as severe tricuspid stenosis, the mean gradient across the tricuspid valve, it should be more than 5 millimeters of mercury. Okay, next, followed by that, coming to the mean diastolic pressure gradient. See, the normal valve area of tricuspid valve is 10 centimeters square, that I have discussed. So significant stenosis must be present to produce a gradient. Okay, so when will you call it as significant tricuspid stenosis? We use the word significant tricuspid stenosis when the gradient, right, when the gradient is greater than, right, when the gradient is greater than 5 millimeters of mercury. That is the point when we use the word significant tricuspid stenosis. And not only 5, even if the gradient is, right, even the gradient is 2 millimeters of mercury, even this can be considered as abnormal. Right, even this can be considered abnormal. Okay, and this particular gradient can be demonstrated by, right, this particular gradient can be demonstrated by echocardiography, right, can be demonstrated by echocardiography and as well as the cardiac catheterization. Right, so that is about the mean diastolic pressure gradient. Now, according to the recent update, so it is 2017 update of 2014 American Heart Association or American Cardiology guidelines suggest a tricuspid valve area of less than 1 centimeter square and a pressure half time longer than 190 milliseconds, right, tricuspid valve area less than 1 centimeter square and a pressure half time longer than 190 milliseconds should be defined as significant tricuspid stenosis, right, should be defined as significant tricuspid stenosis because the gradient may vary depending upon the heart rate, right, because the gradient may vary depending on the heart rate. Okay, now, so the first line investigation is echocardiography. Confirmatory diagnosis is by your cardiac catheterization. And what will be the ECG in patients with the tricuspid stenosis. See, in patients with tricuspid stenosis, you will observe the right atrial hypertrophy. Right, you will observe the right atrial hypertrophy. So how is that you will be able, in the ECG, how is that you will be able to make out that there is right atrial hypertrophy? You can see that here, the P wave, what you will have is, you will have tall P wave. And this tall P wave, we call this as P pulmonale. Right, we call this as the P pulmonale. And what is the criteria to call it as the P pulmonale? The criteria to call it as P pulmonale is the amplitude of the P wave, it should be more than, right, it should be more than 2.5 mm. That is the criteria for the P wave in tricuspid stenosis. Then, and this is the ECG of tricuspid stenosis. Followed by that, and you need to know why you have that P pulmonale. See, once there is increase in the pressure in the right atrium, there will be right atrial hypertrophy. So right atria, it contracts very strongly, and that is the reason why you will have the tall P wave. P wave is due to atrial depolarization. Okay, next. And in the absence of atrial fibrillation, ECG reveals right atrial enlargement. Now in patients with tricuspid stenosis, ECG may also show you the features of atrial fibrillation, because your hypertrophied atria, right, it will be sending abnormal impulses, and that will make the individual to develop the atrial fibrillation. Then what will be the chest x-ray in patients with the tricuspid stenosis? See, the chest radiograph, it may show marked cardiomegaly with normal pulmonary artery size. Okay, so you have marked cardiomegaly, and this particular marked cardiomegaly is mainly because of the right atrial enlargement. Right, there is right atrial enlargement, and that is the reason why these individuals have right, that is the reason why these individuals will have marked cardiomegaly. And what will happen to the pulmonary artery size? Right, there will be normal pulmonary artery size. So that will be the chest radiograph in patients with tricuspid stenosis. And you take the superior vena cava and as well as the azygous vein, there will be dilated right, there will be dilated superior vena cava and azygous vein. Okay, so that will be the chest radiograph in patients with the tricuspid stenosis. So chest radiograph may show marked cardiomegaly with normal pulmonary artery size, and there will be dilated superior vena cava and azygous vein which may be evident. Next, then how do you treat these patients and how is the prognosis in patients with tricuspid stenosis? See, tricuspid stenosis, it is usually right, it is usually a progressive disorder, and eventually, you know, as the severity of the tricuspid stenosis increases, the individual will land up in severe right-sided heart failure. Right, there will be severe right-sided heart failure. And the initial therapy is directed at reducing the fluid congestion with diuretics, and that will be the mainstay of therapy. Okay, so what will be the first line drugs? The first line drugs will be diuretics, right? And what this particular diuretics will do, the diuretics will reduce the fluid congestion, right? Will reduce the fluid congestion. So that will be the first line drugs, that is diuretics. And for suppose when there is considerable bowel edema, right? So when will this bowel edema develops? That is when the individual develops portal hypertension. And when will the portal hypertension develops? Already we have discussed. So because into the portal vein, the splenic vein and superior mesenteric vein will drain. So but when there is increase in the portal venous pressure, the superior mesenteric vein is unable to drain the blood into the portal vein. And thereby the superior mesenteric vein is unable to receive the blood, venous blood from the gut. And thereby there will be development of bowel edema. So when there is considerable bowel edema, torsemide or bumetanide may have an advantage over other loop diuretics. Okay, so torsemide and as well as bumetanide, they have the advantage over the loop diuretics, that is the furosemide. Okay, because this particular torsemide and as well as bumetanide, why they are preferred compared to furosemide when there is bowel edema? Because they are better absorbed from the gut. Right, they are better absorbed from the gut. So that will be the medical management in patients with the tricuspid stenosis. And apart from this furosemide, torsemide and as well as bumetanide, the aldosterone inhibitors, they also help. Okay, so right, aldosterone antagonists, they also help. And these aldosterone antagonists, let me tell you, they are particularly helpful if there is liver engorgement or ascites. Okay, so if there is liver engorgement or if there is ascites, that is the point when you need to give the aldosterone antagonist. And this aldosterone antagonist include the spironolactone and as well as the eplerenone. So this will be the medical management. That will be the diuretics. Then what will be the surgical treatment options? So the surgical treatment options in patients with tricuspid stenosis include: number 1, percutaneous valvuloplasty. Right, percutaneous valvuloplasty. And another important surgical treatment option is tricuspid valve replacement. Right, percutaneous valvuloplasty and tricuspid valve replacement. Now let me first discuss about the tricuspid valve replacement. See, any of these surgical procedure, right, that is surgical tricuspid valve replacement or your percutaneous valvuloplasty, both of them, they are not highly effective for relief of tricuspid stenosis. Why? Because even though you do surgical tricuspid valve replacement or percutaneous valvuloplasty, there may be residual tricuspid regurgitation which is common. That is the reason why neither of these procedure will be effective for relief of tricuspid stenosis. And this tricuspid valve replacement, it is the preferred surgical procedure. Right, so this will be the preferred surgical procedure then compared to that of the percutaneous valvuloplasty. Now, when you are doing the tricuspid valve replacement, you need to make out now you need to make out whether to do a mechanical or bioprosthetic tricuspid valve replacement. And this mechanical tricuspid valve replacement, this is rarely done. Right, this is rarely done because the low flow predisposes to thrombosis. Right, because low flow predisposes to thrombus formation across the valve. And that is the reason why bioprosthetic valves, they are almost always right, they are always preferred. And let me tell you, whenever you are doing the tricuspid valve replacement, the tricuspid valve replacement is performed in conjunction with the mitral valve replacement for rheumatic mitral stenosis or mitral regurgitation. Okay, so whenever you are doing the tricuspid valve replacement, this tricuspid valve replacement should be done in conjunction with mitral valve replacement for rheumatic mitral stenosis or mitral regurgitation. Okay, so that is about your mechanical versus bioprosthetic tricuspid valve replacement. Now, followed by the tricuspid valve replacement, let me discuss about the percutaneous transcatheter valve replacement. Percutaneous transcatheter valve replacement, so this will be the stented valve. Right, so this will be the stented valve. So percutaneous transcatheter valve replacement has been used in degenerative tricuspid prosthetic valve stenosis. Right, degenerative prosthetic tricuspid valve stenosis. Right, so that is about your percutaneous transcatheter valve replacement. Right, and this percutaneous tricuspid valve replacement, this particular device, it is still being investigated. Okay, next, so between these two, which is better? Surgical tricuspid valve replacement is better option, and that too a bioprosthetic valve. So if you see the indications for the valve replacement in tricuspid stenosis, they are straightforward. What is class 1 indication? Class 1 indication includes at the time of operation for left-sided valve disease. Right, at the time of operation for left-sided valve disease. Okay, that is class 1 indication. And the another important class 1 indication is if symptomatic. Right, if the individual is symptomatic. And what is class 2 indication? Class 2 indication, rarely percutaneous balloon commissurotomy for isolated tricuspid stenosis in high risk patients with no significant tricuspid regurgitation you have to try. So class 2 indication, rarely you need to do percutaneous balloon commissurotomy. Right, so percutaneous balloon commissurotomy should be done for isolated tricuspid stenosis, and this percutaneous procedure should be done in those individuals who are at high risk for surgery. So that is about the indication for valve replacement in severe tricuspid stenosis. Right? Now, what is the indication, or when is that the patient of tricuspid stenosis should be referred? All patients with any evidence for tricuspid stenosis on an echocardiogram should be seen and monitored by a cardiologist to assess whether intervention may be required or not. So, if the echocardiography shows tricuspid stenosis, these patients, they have to be referred to the cardiologist and they have to be monitored and they have to be assessed whether intervention may be required or not. So that is about the tricuspid stenosis. So please remember, the most common etiology will be rheumatic heart disease. The other etiologies will be carcinoid, and following that the other important etiologies is after tricuspid valve replacement there can be development of tricuspid stenosis. And clinical features, mainly the features of right heart failure, JVP is elevated, there will be giant A wave, there is mid-diastolic murmur. First line investigation is echocardiography. Confirmatory test is the cardiac catheterization. ECG shows the P pulmonale. The chest X-ray shows cardiomegaly. The treatment, first line drugs will be diuretics, and in those individuals who is undergoing left-sided valvular replacement, in the same patient who is having severe tricuspid stenosis, they have to undergo tricuspid valve replacement. So this is about this very important topic, that is tricuspid stenosis. Thank you very much.